we would be discussing the pathological aspects of testicular cancer. And for that, we would be joined by Dr. Balasingam Balagobi, and followed by we would be having a discussion on decision-making algorithms in testicular cancer. That would be discussed by Dr. Amandeep from India. Dr. Bilal, our radiation oncologist, will be discussing the options of radiotherapy for this cancer. And at the end, Dr. Ali Thavini would be discussing the indications and technique of RPLND. So I would encourage all our participants to post their comments and questions in the chat box. So, Dr. Balagobi, over to you.
Hi, am I audible? Can you all hear me?
Yes, clear. Yes, we can
Good
see
evening.
you and hear you.
Okay, thank you. Assalamu alaikum. I am Dr. Balagobi from Sri Lanka. I'm a professor in urology and a urological surgeon working in northern part of Sri Lanka. So welcome all and thank you very much for the pause for this invitation. So today I'm going to discuss next 20 minutes the pathology of testicular cancer and what are the practical aspects those are useful for a practicing urologist. So the goals of my sessions are classification of the testicular cancer and the pathogenesis, and some basic important information about the common testicular malignancies. Then I will discuss about TNM staging and the practical aspects, and finally tumor markers. So we all know in 20 to 40 years of age, male population, the commonest solid organ cancer is testicular cancer. In the similar age group, in the female, the commonest cancer is a thyroid cancer. So as a urologist, we are dealing with diagnosis and the treatment, then the follow-up management. So it's a teamwork, and we all know the proper specimen marking after orchidectomy or after the retroperitoneal lymph node dissection, and giving the all the information relevant for the pathologist, and negotiating with them and collaborating with them and involving them in MDT. It's very important, the decision making that will give a better outcome in the patient management. So the commonest type of the testicular cancer is a germ cell tumor. It's a 95%. The non-germ cell tumor is 5%. And the common type of germ cell tumor is seminoma. And non-seminomatous tumors, there are different types. The embryonal cancer is a more aggressive type. But if you take the yolk sac tumor, it's common in a pre-pubertal age group. And then teratoma, choriocarcinoma, and the mixed tumors. And if you take the non-germ cell tumor, it can be sex cord tumors like Sertoli cell or Leydig cell tumors, and then other tumors like secondaries, like prostate cancer. After 6 years, if a male coming with a bilateral testicular swelling, it may be a lymphoma. So seminiferous tubule have Sertoli cells, then accompanied by germ cells. So cancers commonly originate from the germ cells. And between the seminiferous tubule, we have interstitium. The interstitial, we have the Leydig cells. So cancer can arise from the either Sertoli cells or Leydig cells. Risk factors can be genetic or personal history, and the undescended testes, or combination of the undescended testes and other features like abnormal sperm parameters and hypospadias, which is known as testicular dysgenesis syndrome, are the risk factors. Now, all the germ cell tumors start with the carcinoma in situ, which is also known as intratubular germ cell neoplasia. So here we can see within a seminiferous tubule, there are abnormal cancer cells, but this is not breaching the seminiferous tubule. So it's an tubular carcinoma in situ type of cancer. So all the germ cell tumors they develop from the carcinoma in situ. So if you know the pathogenesis, during the fetal development and later, there are genetic defects starts, and they develop the germ cell neoplasia even before the puberty. But after the puberty, due to the hormonal influences and more proliferation of cells and more mutations, and ultimately they develop invasive carcinoma. So primordial germ cells and mutations and carcinoma in situ, more mutations and more events, and then the invasive carcinoma. So most of the people, this is a normal pathway. Germ cells become spermatocytes. So some areas in some people, some germ cells become abnormal because of the mutation, and they proliferate and become invasive carcinoma. So it may be a seminoma or non-seminomatous cancer. So if you take the seminoma, as I said earlier, it's the most common germ cell tumor, common between 30 to 40 years of age. In the cross section, it looks like a cut section of the potato, whitish, bulky, lobulated. Usually, we won't see any necrosis or hemorrhages that we see in our non-seminomatous tumors. Histology, the classical cells, a lot of clear cytoplasm and centrally located dark nucleus with uh, densely colored the nucleoli. So they look like the fried egg appearance. And in between, we see the septa, which is heavily infiltrated by lymphocytes. So that's appearance we will get in the seminoma, which is very common uh, germ cell tumor. If we do the ultrasound scan, we will see a homogeneously abnormal testis. So I will summarize those relevant radiological imaging findings later. We take the embryonic carcinoma is a very aggressive cancer. Contrast to the seminoma, which is occurs in the fourth decade, but this is occurs about 10 years before the third decade. And usually we will see infiltration into the adjacent structures. So that's we will see the lymphovascular invasion as well. Yolk sac tumor is another type of non-seminomatous germ cell tumor, which is common in pre-pubertal age group. And when compared to other cancers, good prognosis and secrete the alpha beta protein. And in the microscopy, we will see the typical appearance of ciliary dual bodies. Looks like a glomeruli. So that's a typical appearance we will get in the yolk sac tumor. And the choriocarcinoma is another aggressive cancer. It almost always secrete the HCG, and patient might come with the lung mets or the brain mets. Even if you do a urine HCG pregnancy test, it will be positive. And so it's a kind of aggressive tumor, the choriocarcinoma. Teratoma is two types. It can be a mature teratoma. Usually the mature teratoma is a benign and it occurs in the pre-pubertal age group. An immature teratoma, which contain immature the germ cell derivatives, which is malignant and usually occurs in the post-pubertal age group. So mature teratoma contain mature tissues from endoderm, ectoderm, and mesoderm, so like teeth, hair, cartilage. But immature teratoma contain immature tissues. So the malignant teratomas, that is post-pubertal teratomas, are usually resistant to the chemotherapy. So if there is a lymphadenopathy, if they are more likely to get the residual tumors and more likely to, we had to go for a resection, surgical resection. So that's then the mixed tumors. So we have discussed about different type of non-seminal germ cell tumors. Now mixed tumors will contain all tumors like teratoma or maybe embryonal carcinoma or maybe yolk sac tumor. The prognosis is depending on which is the dominant type. Whether it's a embryonal type, then it's more aggressive mixed tumor. And the tumor markers also based on what the component of the major component of the tumor. Spermatocytic tumor is a variant of seminoma, which is common after 6 years of age, old people. But this is a benign tumor. So it's have a benign course and it's not originate from carcinoma in situ. So sex cord tumor, commonly two Leydig cells tumor and the Sertoli cell tumor. If you take the Leydig cell tumor, which secrete traditionally androgen, but it can secrete the estrogen as well. And these are more benign tumors when compared to the germ cell tumors. And so as they are secreting different hormones, so the patient can come with the gynecomastia, or if the prepubertal child may come with the early puberty. And it can be associated with Klinefelter syndrome uh, and undescended testes. So here we have a classical type of crystals in the histology in Leydig cells. These are known as Ringy crystals. So those crystals are visible in the microscopy, again, which is characteristic of Leydig cell tumor. Sertoli cell tumor, again, very rare, but again, they can secrete the different hormone, and usually they are benign in prognosis. Testicular lymphomas, not common, but it can occur after 6 years of age. Frequently, the patient come with the bilateral, firm uh, enlargement of the testes, but it can be any type of different lymphomas. We take the TNM stage, so carcinoma in situ, the T1 confined to the testes, no lymphovascular invasion, and T2, either lymphovascular invasion or the tumor is infiltrating into the tunica vaginalis. T3, invade the spermatocord. T4, invade the scrotum. So usually we won't do any biopsies in testicular tumors. We know that otherwise we will upgrade the tumors. So traditionally we do a radical inguinal orchidectomy, except some few conditions. We will discuss that. And lymph node, based on the size and number, N1, N2, N3. M1A is paraortic lymphadenopathy or any other non-regional lymph node enlargement and the lung mets, but other mets like liver and other visceral organ mets are M1B. Here we had to know that in the TNM stage, the tumor markers are involved. One of the tumor markers are in the TNM stage. So before surgery, before orchidectomy, doing LDH, HCG, and alpha fetoprotein is a must because that's give the stage where S1 or S2 and prognostically important. And follow-up also is very important. So in a proper pathological report, all this information should be there. And when we are filling the form, we have to give all the information to the pathologist, including the tumor markers and the clinical findings, and any risk factor we identified. So the pathology report should have the tumor type, which type of germ cell tumor, the size, margins, and the lymphovascular invasion status, whether retitestis is involved or not, and the counts of the tumor markers. So as I said, the ultrasound imaging and the pathology most of the time correlate. Some radiologists straight away they can say in ultrasound scan, this patient is having a seminoma. The reason is a homogeneous appearance in ultrasound scan, seminoma. But if you take the non-seminomatous tumor, just keeping the ultrasound probe, you can get a idea. It will be a heterogeneous tumor with a lot of calcification. But in case of teratoma, we will see a cystic area with solid component inside. That's a feature of teratoma. So most of the radiologists, by doing the scan, they can correlate the pathology. So the frozen section is rarely done in testicular cancer, especially if we are going for a organ sparing surgery in case of solitary testis or bilateral testicular tumor. Then we had to do the frozen section, but we are very careful. The pathology should be very experienced, and there may be a sample error and artifact error with the frozen section. And clinically, patient comes with painless enlargement of the testis, or they say heaviness of the scrotum, but they can come with metastatic features like shortness of breath or lymph nodes enlargements. Also, patient can come with pain really because they're bleeding inside the testicular lesion. They can come with the pain. Serum markers already I have discussed. Alpha-fetoproteinase increase in the non-seminamatous germ cell tumor is never increased in the seminoma, and beta HCG 100% increase in cholangiocarcinoma and also in some seminomas. LDH is not a real tumor marker. It's actually indicate the burden of the tumor. The higher value, the higher tumor burden. So serum tumor markers are useful in diagnosis, in staging, and also in follow-up. So if you take a seminoma, which is more radiosensitive and more hemosensitive, so they melt like ice when you give one of these treatments. So it's best prognosis. So even with the metastasis, the prognosis is excellent in seminoma and quite good in non-seminomatous tumor as well. So in conclusion, as a urologist, the proper surgical surgery, the radical ocherectomy, and giving all the information to the pathologist and marking the specimen properly and communicating with the pathologist and involving with the pathologist is very important. And 95% of the tumors are germ cell tumors. They originate from carcinoma in situ. And seminoma is the commonest germ cell tumor. The embryonal cancer and choriocarcinomas are aggressive cancer. And few cancers have their specific features in the histology. Tumor markers useful in both diagnosis and follow-up. And that's all I want to say in the pathology of the testicular cancer. Thank you.
Thank you, Dr. Balagobi. It was nicely summarized, the histopathology of testicular tumor with emphasis on more practical aspects. Our next presenter would be Dr. Amandeep Arora, and he would be talking about decision-making algorithms in testicular cancer.
Hello, Dr. Wajahat. Good evening. Am I audible and are my slides seen?
Yes, we can see you, we can hear you,
Okay, great. All right.
and we can
First of
see the
all,
nice picture of it. Yeah.
yeah. So first of all, thank you very much for inviting me and having me speak in this forum. I'm Amandeep Arora. I'm an associate professor in Uro-oncology at the Tata Memorial Cancer Hospital in Mumbai, and I've been asked to speak on the decision-making algorithms in testicular cancer. This is what I would like to cover in the next 20 minutes allotted to me. Diagnosing and staging a testicular cancer patient, because we need to know that before we start planning our treatment. some slides about management principles, because these patients are very different from other cancer patients that we treat. And finally, what are the treatment options stage wise? First, stage 1 seminoma and non-seminomatous germ cell tumors, then stage 2 disease, and then advanced germ cell tumors. It's a lot to be done in 20 minutes, but I'll do my best to give you as much information as I can and also try to stick to time. Coming first to diagnosis and staging. So as we just saw in the previous speaker's slides, patients usually come to us with an ultrasound done, right? So they have experienced that one of the testes is growing in size, they've got an ultrasound done locally, and then they come to us because the ultrasound report is not great. So this is how it is seen. The testis usually looks very homogeneous when it's normal, but when there is a lesion inside it, ultrasound is very, very good to pick it up. And you may usually have such a report that a 7 by 7 or a 5 by 5 centimeter lesion is seen, irregular, lobulated, and if a Doppler is put in, they might even be able to see some increased vascularity in that mass. Next thing that we would want to do in the clinic for these patients are tumor markers. AFP, beta HCG, and LDH are the 3 tumor markers that we want to do. We have these half-lives, and these half-lives are very important, and I'll tell you why later on. Classically, AFP is increased in embryonal and yolk sac tumors, beta HCG in some of seminomas and in choriocarcinomas. LDH is raised in some seminomas, but it's a very non-specific marker. So we obtain tumor markers before orchidectomy and also post-orchidectomy. Why post-orchidectomy? Because when we do our staging for germ cell tumor, it has an S category, and the S category is actually markers done after the orchidectomy. Okay, and we do it after 5 half-lives. So that is why we had the half-lives in the previous slide. So we do it after 5 half-lives so that they have come back to normal. So AFP, so we give them a chance to come back to normal. Okay, so AFP has a half-life of about a week. So we wait for about 4 weeks, that is about a month after the orchidectomy, and then repeat the markers to check whether they are coming back down to normal or not. Okay, and the post-orchidectomy markers, not the pre-orchidectomy ones, the post-orchidectomy markers are the ones that are used in staging. And for rare patients with advanced disease, some patient has come to you with a CT scan showing multiple lung mets, large testicular mass, large retroperitoneal mass, you do tumor markers and the tumor markers are elevated, and you know that this is a patient of germ cell tumor. In such a patient, even without doing an orchidectomy, there is a case for proceeding directly to chemotherapy, because this patient cannot wait for the orchidectomy to happen and then for the chemotherapy to start. Okay. Now, once you have the tumor markers also in place and you are thinking in lines of a germ cell tumor, you need to do some imaging, and the imaging is a contrast enhanced CT scan of the chest, abdomen and pelvis. This scan will tell us the N and the M staging for the tumor, and the retroperitoneum is the initial site of spread for most of our germ cell tumors. Some of them can also have hematogenous spread, so you'll have mets in the lungs, liver and bones, most commonly in the lungs. These are the landing zones for germ cell tumor. Okay, so from the right testis, lymphatics go to the interaortocaval lymph nodes first, not paracaval, interaortocaval, followed by paracaval and paraaortic. The left side goes to the paraaortic first. Spread happens more from right to left than from left to right. And after the retroperitoneum, they go via the cisterna chyli into the retrocrural lymph nodes, the thoracic duct, and the posterior mediastinum and the left supraclavicular nodes. Okay. Now there is no consensus for size criteria for what is a significant node. 1 centimeter is usually what is most commonly written. This is a line from Campbell. Nodes 5 to 9 mm in the primary landing zone should be viewed with suspicion, particularly if they are anterior to the great vessels. Okay, so pre-caval, pre-aortic, interaortocaval lymph nodes are very significant even if they are more than 5 mm in size. Germ cell tumors grow rapidly, so our treatment decisions should be based on imaging done only less than 1 month prior. Do we do an MRI ever? So we do an MRI only if a CT is contraindicated if the patient has some creatinine issues. We do an MRI brain in some patients, not in all patients. So these are the indications in which we would want to do an MRI brain. When the beta HCG is more than 5,000, so we are thinking in terms of a choriocarcinoma and they are prone to have brain mets. Non-pulmonary visceral mets. So if a patient has liver mets and bone mets, you would definitely want to check the brain. If somebody has extensive lung mets, that is again an indirect marker that the patient might be having choriocarcinoma and you would want to see the brain. And obviously if the patient comes to you with any neurological symptoms from the brain, you would want to image the brain. There is absolutely no role of doing an FDG PET CT in the initial staging of our patient, so do not do it. The next step that we do is a high inguinal orchidectomy, and as we heard from the previous speaker, we are doing it to get the T stage for the patient and also to confirm that yes, we are dealing with germ cell tumor and to get more information about the germ cell tumor. And what is the more information that we'll get? This is what our report should tell us. The histological type, whether we are dealing with seminoma or non-seminoma, what is the size of the tumor, whether it is unifocal or multifocal, whether there is a retinal involvement and invasion into the other structures that are written here, whether there is presence of germ cell neoplasia in situ, whether there is LVI, what is the margin of the cord that we have cut at the deep ring, and what is the relative proportion of each individual subtypes. The previous speaker told us about different subtypes of germ cell tumor. We would want to know the relative proportions of each of them in the orchidectomy specimen. Finally, now that we have done the orchidectomy, we have our tumor markers done after the orchidectomy, and we have the CT scan. We are now ready to assign a stage to our patient. Okay, so the T stage, T1 is tumor limited to the testis without LVI. T2 is still limited to the testis but has LVI. T3 is something which goes to the spermatic cord, and T4 is when the scrotum is also involved. The end stage, N1, is the lymph node less than 2 centimeter. Where is the lymph node? In the retroperitoneum, seen on the CT scan. N2 is more than 2 but less than 5 centimeters, and N3 is a nodal mass more than 5 centimeters. What is the M stage? M1A is non-regional lymph nodes. Means what? Mediastinal nodes, cervical nodes, supraclavicular nodes. Okay, so any nodes which are not in the retroperitoneum, and also lung mets. Okay, so M1A is also lung mets. So you need to remember that lung mets are not so bad in a germ cell tumor patient. Okay, M1B is non-visceral lung mets. Okay, which means that there are mets even in the liver or the bones. Okay, and very classically, the T and M staging for testicular cancer also has the S stage, which means the tumor markers, and these tumor markers are done at least 4 weeks after the orchidectomy has been done, and we grade them as S1, S2 and S3. Now with the T, N, M and S available, we can assign a stage to our patient. Okay, so as you can see, so don't go through the entire chart, just go through the animations. Stage 1 is tumor confined to the testis. Okay, T can be anything, but there are no nodes on imaging. This is tumor confined to the testis. What is stage 2? Stage 2 is now the disease is in the nodes also, and 2 is broken down into N1, N2 and N3. So 2A is N1, which means less than 2 centimeter nodes. Stage 2B is N2, means 2 to 5 centimeters nodes. Stage 2C is N3, which is nodes more than 5 centimeters. Okay, and then we have stage 3. Stage 3 means now we have metastatic disease, means we have M1 disease, means we have nodes outside the retroperitoneum or lung mets or other mets. Okay, stage 3A is M1A and S1. Stage 3B is S2, means the markers have increased now, and stage 3C is M1B and S3. It is extremely difficult to learn this, especially when you have multiple cancers, TNM staging to learn. But this is broadly how I've tried to highlight what is the difference between the different stages. One thing to remember here, there is no stage 4 in testicular cancer. Even metastatic disease is counted as stage 3 disease. And for our stage 3 disease, we have something called as International Germ Cell Cancer Collaborative Group, IGCCCG risk stratification. So what does this collaboration tell us? This collaboration gives us risk stratification for our advanced seminoma and non-seminoma patients. Why is this important? Because this is exactly what guides management. Okay, again, don't look at the entire chart and don't try to learn it. This is for seminoma. You need to see that there are 3 risk categories: good, intermediate and poor. For seminoma, there is no poor category. Okay, which should intuitively tell you that seminoma is better than non-seminoma. Okay, so in seminoma you can only have a good risk patient or an intermediate risk patient. Okay, and as you see in the animation, a good risk patient does not have any liver mets. Okay, so you can have lung mets, but you cannot have non-pulmonary mets. Okay, and the moment you have non-pulmonary mets, you become an intermediate risk patient. Okay, and no patient is a poor risk patient for seminoma. Coming to non-seminoma, you first check whether there is mediastinal primary. Okay, we are talking of testicular cancer, but testicular cancer can start directly in the retroperitoneum also, which we call primary retroperitoneal germ cell tumor. It can start directly in the mediastinum also, which we call primary mediastinal tumors. So if the tumor is primary mediastinal, or if there are non-pulmonary visceral mets, means what? Liver mets, bone mets, then the patient has poor risk disease. If these are not there, then you check the markers. If the patient has S1 marker, the patient is a good risk disease. S2 markers, intermediate risk disease. S3 markers, poor risk disease. And again, these markers have been done at least a month after the orchidectomy was done. Okay, so that was about evaluating your patient, doing some investigations, doing the orchidectomy, doing the CT scan, and finally assigning a TNMS and stage to your patient. And if that stage is stage 3, then you need to also assign the risk category to your patient depending upon the IG-CCCG risk classification. Okay. Now, coming to management of these patients, so some basic management principles. We need to aim for cure in our patients. Okay, these are young patients, they have good ECOG, so we can do aggressive management, and aggressive treatment is undertaken because of the possibility of cure even in the presence of metastasis. Even metastatic germ cell tumor patients can be cured. Aggressive surgical surgeries are done to resect all residual disease after chemotherapy. And one thing which you need to remember regarding teratomas, they are not FDG avid, they are not chemosensitive, they are not radiosensitive, and they do not produce tumor markers. This is something that we need to remember when we are planning treatment for our patients. Another very important thing for our patients is preserving fertility. Most of our patients are young and they would desire to father children in the future because they will get cured of their disease. So we need to document semen parameters before starting treatment. In case of advanced disease, we need to do sperm cryopreservation prior to starting chemotherapy if it was not done prior to the orchidectomy. Assisted reproductive techniques can be used later if cryopreservation was not done. And if cryopreservation was not done, fertility sometimes returns in some patients after 1 year if only one chemo was done, but it can take 3 to 4 years if 4 cycles of chemotherapy were given. Now coming to actual stage-wise management of our patients. Stage 1, seminoma. Okay, so this is seminoma and the stage is 1, which means that the tumor is confined only to the testis. Okay, so 10 to 15% of our patients with stage 1 seminoma will still have occult mets. It means that your CT scan is saying there are no nodal mets, but 10% patients still have micrometastatic disease in the nodes. So our further treatment options include either surveillance for our patients or adjuvant radiation therapy or adjuvant chemotherapy. And this decision depends upon the patient's risk status and compliance with follow-up. And the risk factors that we take into account are 2 things from our pathology report: whether the tumor size is more than 4 centimeters and whether there is invasion of rete testis or not. Okay. So what about surveillance? It's one of the options for our stage 1 seminoma. So the rationale is that only 10% patients have occult mets. So if you do surveillance for patients, only 15% patients will recur. Remaining 85% patients will not have a recurrence. And the cancer specific survival with stage 1 seminoma is close to 99%. Means that even if those 15% patients have a recurrence, that recurrence can be salvaged with some treatment, and no patient is going to die of seminoma just because you chose surveillance for stage 1 seminoma. This is the protocol. We do 3 monthly scans in the first year, then 6 monthly till the 3 years, and then annually. We can replace CT scan with MRIs also. Tumor markers are optional because I told you seminomas don't produce tumor markers. And chest X-ray as indicated. In our institute, we do a CT scan of the chest, abdomen and pelvis. We don't do an X-ray. The advantage of surveillance is there is no toxicity because you're not giving any more therapy to the patient. The disadvantage is that you need to repeat CT scans and the patient needs to be very compliant with strict follow-up. The other option is you could give chemotherapy to your patients. So if the patient has 1 or 2 of the risk factors that I told you, size more than 4 centimeters or rete testis involvement, then we should ideally not be doing surveillance for our patients, and what we can do is give them chemotherapy. What do we give them? We give them a single agent of carboplatin. 1 cycle is enough. That is the dose which our medical oncologists calculate. The 5-year DFS is very high, 96%, and after chemotherapy we do annual CT scans to follow up our patient, and because it is only 1 cycle, there is really no long-term toxicity. We can also do radiation therapy for our stage 1 seminoma patients, and I think our next speaker will discuss this in detail, so I'll probably skip this slide. So this is from our EAU guidelines. This is stage 1 seminoma conclusion. We'll read every line one by one. Offer surveillance as the preferred management option to our patients if the patients are compliant. Okay, why? Because only 10 to 15% patients will fail your surveillance. You offer 1 dose of carboplatin at area under the curve 7 if you decide for chemotherapy. Do not perform adjuvant treatment in patients at low risk of recurrence, which means no risk factors. And if you do have a risk factor, you give the chemotherapy. Routinely, we would not give radiation therapy to our patients. What about stage 1 non-seminomatous germ cell tumor? So stage 1 non-seminoma means the markers were high, you've done the orchidectomy, and after a month the markers have now come back to normal. In stage 1 non-seminoma, occult mets can be present in 25 to 30% of patients. It's higher than seminoma, so surveillance is not that preferred. And what are the high risk features in the pathology report? LVI and predominance of the embryonal component. There it was rete testis and size more than 4 centimeters. And the options available are surveillance, just like seminoma, chemotherapy like seminoma, but the chemotherapy is different. Here we don't do radiation therapy and we can offer RP-LND to our patients. Okay. Now, how do we do surveillance for our stage 1 patients? Same way, the way we used to do for our seminoma patients. That is the protocol. But the risk of failing is a little high because 25 to 30% patients will have micrometastatic disease. So if you have no risk factors, you can still do surveillance for your patients. But if you do have risk factors, you should probably not be doing surveillance for your stage 1 NSCCT patients, although you could do it for your seminoma patients. Now coming to, if you want to give chemotherapy to your stage 1 NSCCT patient, there we were giving single cycle of carboplatin. Here we give a single cycle of BEP. The relapse-free rate is again excellent, more than 95%. One cycle is enough, you need not give 2 cycles. And there is again no significant long-term toxicity because you are giving only 1 cycle, and it is the preferred treatment option in patients who have high-risk features. Now, if somebody does not want to undergo chemotherapy or is not fit for chemotherapy but has high-risk features, then such a patient cannot be put on surveillance. There is something else that you can do for this patient, and that is RP-LND, retroperitoneal lymph node dissection. Nerve sparing should be done. It should be done at centers of excellence because this is a complex surgery. But some patients can do have a relapse and then they may need more chemotherapy. This is how it looks, the template looks after we've done a nerve sparing retroperitoneal lymph node dissection. Those things in the vessel tapes are the nerves that we have preserved between the cava and the aorta. Okay, so this is the conclusion of stage 1 non-seminoma. So again, you need to see the pathology report, check whether the patient has risk factors or not. If there are no risk factors, that is low risk on the left side of the page, you need to do surveillance. If you cannot do surveillance, give them 1 cycle of chemotherapy. If it is a high risk patient, your standard option is 1 cycle of chemotherapy. If you cannot give chemotherapy, either do RP-LND in a center of excellence or put the patient on surveillance. Okay, so that was stage 1 disease. That is tumor limited only to the testis. Coming to stage 2 disease means what? The tumor is now in the nodes in the retroperitoneum. So your CT scan has picked the nodes. We'll first talk of seminoma. Stage 2A and 2B means what? The nodes are either 2 centimeters in size or 2 to 5 centimeters in size. So that is also divided into 2A and 2B. For 2A, our guidelines tell us that you should give 3 cycles of chemotherapy. If the patient cannot take chemotherapy, then we can give the patient radiation therapy, and that will be discussed, I think, by our next speaker in detail. If you have stage 2B disease, again the preferred regimen is chemotherapy. You may give radiation therapy at a higher dose to these patients because the node is bigger in size. Coming to stage 2A NSCCT, the previous slide was seminoma. That is why we had chemo and radiation therapy. Now we are talking about NSCCT. In NSCCT, we do not have radiation therapy. Okay. So for stage 2A, 2A means there is a less than 2 centimeters node and the markers have come back to normal. So now you are not sure why is that node seen on the CT scan. The patient's markers are normal. So then what is that node doing? So what we can do is we can observe the patient and repeat the CT scan after 4 to 6 weeks. If that node resolves, continue surveillance. If the node is stable, then it might have teratoma. Teratomas don't produce tumor markers, and that is why your patient is S0. So you do a nerve sparing RP-LND for your patient and then decide whether you need to give more chemotherapy or not. If this node actually increases in size, then the doubt is solved and this patient needs an RP-LND. And if the markers also increase on surveillance, then the patient actually needs chemotherapy. There is one more stage of stage 1, which is stage 1S. 1S means the tumor is confined to the testis. Your CT scan shows no nodes, but your markers have not come back to normal. This is called stage 1S. For stage 1S patients, we give some more time for the tumor markers to try to come down to normal, and we repeat the CT scan and the tumor markers in 4 to 6 weeks. But if they have still not come down to normal, then this patient actually needs chemotherapy, and 3 cycles of chemotherapy are given to these patients. For our advanced germ cell tumors, which is stage 2C and stage 3, okay, as I told you, these patients need to be risk stratified as per the IgCCG classification. So for our good patients, we give 3 cycles of BEP or 4 cycles of EP. For our intermediate risk patients, we give 4 cycles of BEP. And if the patient cannot take bleomycin because of lung toxicity or a lot of lung nodes, then we replace bleomycin and give VIP 4 cycles. And if it is a poor risk patient, which can happen only in NSCCT, as seminomas don't have poor risk patients, again this needs 4 cycles of chemotherapy. That is the chemotherapy: bleomycin, etoposide and cisplatin, and the cycle is given every 21 days. And if you cannot give chemotherapy BEP, or if the patient progresses on BEP, then we have these other regimens available: VIP, TIP. Okay, I think I've finished my time, but I have just 4 or 5 slides more left. I'll probably take 2 or 3 minutes more. Now, so you've given chemotherapy for your advanced germ cell tumor patients. They had big nodes, big mets. You've given chemotherapy. Now what? So now after the chemotherapy has completed, if the patient was a seminoma patient, you do a PET scan after 8 to 10 weeks. This is the first time in the entire presentation that I'm telling you to do a PET scan. Okay. So we do not do a PET scan at baseline for staging our patients, but in our seminoma patients, after the chemotherapy has been given, we do a PET scan after 8 to 10 weeks, not after 3 to 4 weeks. Why do we wait so long? Because seminomas keep responding to chemotherapy even after the chemotherapy has completed. So we give enough time for the entire action of chemotherapy to come. And then in the PET scan, we look at the size of the residual tumor mass and the SUV max of that node. If the size is less than 3 centimeters and the SUV max is also less than 3, we observe these patients. If any of these parameters is high, then ideally we should biopsy. If the biopsy is negative, we keep the patients on surveillance. If the biopsy is positive, our guidelines say we should do salvage therapy. It is not mentioned what salvage therapy should be done. Should we give more chemotherapy? Should we do RPLND? Should we do radiation therapy? It is not well known what should be done in seminoma. We have a trial running in our hospital, at Tata Memorial Hospital, where we are randomizing these patients to observation versus radiation therapy. We are not too keen to do RPLND for these patients because post-chemotherapy RPLND for a seminoma has a lot of complications. For NSCCT, in your post-chemo residual mass, you do your CT scan. Here you don't do the PET scan. Why? Because teratomas are not FDG avid, right? NSCCT can have teratomas, and if you have a teratoma inside, it will not light up on your PET scan, so you will not come to know anything. So you do a CT scan only 3 to 4 weeks after completion of the chemotherapy, and then you do an RPLND for our patients. RPLND will be discussed in detail by our next speaker, so I'm not touching on that. FDG PET is not recommended. Okay. Now, if you have complete remission, which means after the chemotherapy, everything has disappeared on the CT scan, tumor markers have come down to normal, then you just keep the patient on surveillance and don't do RPLND. If the residual mass is less than 1 centimeter, the role of RPLND is uncertain. We could do RPLND if the patient had very bad disease initially to begin with. Okay. But if there is anything more than 1 centimeter, RPLND is mandatory. And this is how we follow up our patients. We do intense follow-up in the first 1 to 2 years. Every 3 months we call them, and then we gradually increase the interval to every 6 months, and then after 5 years we do it only annually. So last slide to summarize. For our stage 1 seminoma patients, surveillance versus chemotherapy versus radiation therapy, and you decide based on whether the patient has risk factors or not on your pathology report. Stage 1 NSCCT, again surveillance versus chemotherapy versus RPLND, no radiation therapy here. Again decide based on risk factors. Stage 2 disease, if you have seminoma, prefer chemotherapy, you could also give RT. Stage 2A NSCCT, you could do initial surveillance for your patient because it's only a small node. But if you have bigger nodes and if you have metastatic germ cell tumor, you have to give these patients chemotherapy. After chemotherapy, if you have a seminoma, either do surveillance for your patients if they've shown excellent response, or give radiation therapy, no RPLND. But if you have a non-seminomatous germ cell tumor, you either do surveillance if there is a complete response, but if there is residual disease, then you would want to do retroperitoneal lymph node dissection for your patients. All right. Thank you so much.
It's nicely explained, Amandeep. Especially, I liked how you clearly defined the current role of PET CT scan in management guidelines. Otherwise, especially in our tumor boards, the radiology, the oncology people are very much fond of doing PET scan, and it appears that some people think that it is the answer to every question, but very nicely explained. So, Dr. Bilal, our radiation oncologist, would be next. Bilal, over to you.
Thank you so much, Dr. Vajat, and the organizing team for having me here to speak about the radiation therapy for testicular tumors, and very nicely summarized by Dr. Mandeep, the algorithm for making decisions. So thank you, Dr. Mandeep, for leaving behind slide number 27 and 37 in your presentation so that I could do some justice to radiation treatment during these 20 minutes. So I would not go into a lot of details here, which have already been talked about, but I just wanted to emphasize upon the anatomy of testicular tumors, because this is the knowledge that we need to know, based upon which my talk would base, like why do we do radiation therapy to a specific area, and why we have the next door that talk, that is retroperitoneal lymph dissection, because the drainage of the testicular tissue is into the parietal lymph nodal area, and it's not directly absorbed an echelon into the inguinal node or the lower or upper pelvic nodes, unless the scrotum is violated, which is absolutely advised to be avoided, so that unnecessary radiation or upstaging of tumor does not happen. So thank you, Dr. to our pathologist, for summarizing the the histopathology in detail, and what I would be talking about would only the role of radiation therapy in seminoma, because this is a very sensitive treatment. So, as Dr. Mandeep summarized on his slide number 25, that usually the stage 1 testicular tumors have a very good prognosis. Every effort should be done to keep the patient on follow-up and follow a surveillance protocol and avoid any adjuvant treatment in those situations, because as we just discussed, that most of these patients have a very good survival. A few of them, the relapse rate may be higher for the primary tumor being more than 3 centimeter, but still, those patients who do relapse, they have a very good salvage rate and similar survival for patients who do not recur. And adjuvant treatment, be it in any form, be it systemic treatment or radiation therapy, it must be very clear to the patient that it's not the number of years that is what with this adjuvant treatment as compared to surveillance or close follow-up. It's only decreasing the risk of relapse and avoiding a second kind of a treatment later on. The overall survival does not improve with any kind of adjuvant treatment, be it radiation therapy or chemotherapy. And the role of radiation is only limited to stage 1 and stage 2 and 2B seminoma. So for stage 2B seminoma, especially when the nodes are less than 3 centimeter, radiation therapy could be offered, and it's 2 to 3 weeks treatment with 20 gray offered to the paraortic region and the upper pelvic nodes, and a boost to the nodal residual disease that is seen in the CT scan. I have added the option of chemotherapy, which Dr. Amandeep also emphasized upon being the preferred treatment rather than opting for radiation therapy, and that could be understood in the context of the effects of radiation therapy, especially second malignancy, and I have a slide on that later on. So the radiation therapy for pure seminomas in such situation is limited to stage 1A and to stage 1 and stage 2 and 2B disease. advised with a curative intent in a post-operative setting to cover the microscopic disease or disease which is less than 3 centimeter inside in the parietic region. The patient lies supine, looks armed at the side. We make some arrangement to immobilize the patient by putting something on the patient's knees to avoid patient moving, and we try to move the benign tissue away from the radiation field and provide a clamshell shield for the remaining of the testicles over the scrotum so that they are not getting radiation therapy in the direct radiation field. So you can see doses which are respectively for stage 1, 2A, and 2B being less than or more than 3 centimeters inside. The treatment would be given for one of these stages. So radiation therapy is typically started after the orchiectomy wound has healed. And by orchiectomy, I definitely mean inguinal orchiectomy, scrotal orchiectomy, or scrotal biopsy, highly avoided. Some form of emetic medication could significantly improve nausea, which may happen during radiation therapy, and some studies suggest that anti-emetic treatment given prophylactic session 2 hours prior to each fraction of radiation therapy may help avoid the side effects of radiation therapy. And whenever a decision is being taken to offer radiation therapy, the fertility. Nowadays, we do radiotherapy planning with the patient in supine position using CT simulator with the mobilization devices I just mentioned, and special precautions are taken to avoid the penis and the scrotum out of the radiation treatment field. For pure seminoma, either a dose of 20 grain 10 fractions would mean that since radiation therapy is offered 5 fractions a week, so for stage 1 seminoma, is going with the next fraction of 2 grain per fraction would be done within 2 weeks, and the fractionation of hyperfractionation with 1.5 grain per fraction would mean the radiation therapy around 3.5 weeks. For stage 2 seminoma, an initial larger field is treated with a dose of 20 grain in 10 fraction, and I'll be adding some illustration in the next few slides to understand the field or the area of treatment. So a larger area for microscopic disease is covered with radiation therapy of a dose of 20 grain 10 fraction for the first 2 weeks, and depending upon the size of the residual disease in the nodal region, a boost is given to complete a dose of up to 36 grain. So an extended field beyond the parietic region is used, which is called the TEC dogleg field. In certain situations, who have had an unfortunate prior inguinal surgery, be it for any reason, no positive disease or treating patient is salvaged for recurrence. So here you can see a dogleg or a hockey field which covers the area around the parietic region, extending inferiorly to L to the upper cervical, upper pelvic nodal area, with the upper border being at the superior border, lower border being at the superior border of the obturator foramen, and the upper border at the T10-11 junction. We have to particularly look after the left-sided renal hinum for left-sided humor, explained by the previous surgeon, the previous speaker, depending upon the lymphatic drainage of the left side. So a particular parietic strip for stage 1 pure seminoma, where radiation therapy is being opted extend from the T10, T11 thoracic vertebral body junction up to the L5, S1 junction. And laterally, it should encompass the transverse processes of the corresponding vertebra. And these are the conventional fields that have been used. For stage 2A and 2B tumors, the radiation treatment field, if the one region is not at risk, should be extended inferiorly to the upper border of the acetabulum. The midline pelvic and the contralateral pelvic structures are shielded to avoid the effects of radiation therapy, and a considerable margin should be given around the microscopic disease in stage 2 tumors post orchiectomy to cover them adequately. Following that, a boost is given to a total of 30 to 36 grade with the residual nodal disease with some margin around it. So for radiation therapy planning, we have to be very careful about the fertility effects. At very low dose of 50 centigrade, a transit into spermia may happen and can cause permanent sterilization at a lower dose of 200 centigrade, which is around 10% of the total dose. So all of efforts should be done to preserve the sperms before orchiectomy or through the contralateral testicular procedures. So before a patient opts for radiation therapy, the radiation treatment-related toxicity must be discussed. The highest and the most important one are infertility and secondary malignancy. With modern treatment technology, nephrotoxicity can be avoided. It's going to be happening. Gastrointestinal effects as well as skin tanning of the teeth during the course of radiation therapy or in the immediate few weeks after the radiation therapy. So a couple of things that I would like to discuss about the tumors, treating these tumors on the conventional technology. We talked about the conventional field, but nowadays radiation treatment planning is done through a CT scan. A certain margin is given to cover the microscopic disease in the para-aortic region, and this corresponds to around 5 to 7 millimeter margin around the vessel, which are zero vena cava and the para-aortic region, because that's the region where these wounds lie. And then around 8 millimeter margin is given around a gross node to cover the visibilities. So some of the other scenarios where radiation therapy may be used for primary testicular tumor. I know this thing changes the flavor of today's session. We are mostly concentrating upon the testicular tumors, the testicular germ cell tumors today, because they are the primary tumors arising from the testes. But some other situation where radiation therapy is used for testicular or paratesticular tumor includes pediatric rhabdomyosarcoma, which are of course usually arising from the paratesticular tissue, but they get diagnosed in point of orchiectomy. They often require a higher dose of radiation if there is any evidence of microscopic disease left behind in the nodal region or in the testes, and they often require you to peritoneal lymph node dissection, even to detect the microscopic disease, especially for children more than 10 years of age. Other tumors which require radiation therapy for testicular tumor, the malignancy include acute lymphoblastic leukemia, if they do harbor disease in the testes upfront, or when there is a situation that the tumor relapses into the testes after the entire chemotherapeutic treatment is completed, because sanctuary, like the brain and blood-brain barrier, is considered to be a sanctuary sites, and therefore a testicular boost may be required. There are certain situations like testicular lymphomas where post-chemotherapy radiation may be required, and of course there are sarcomas arising from the spermatic cord or paratesticular tissue like leiomyosarcoma, where radiation therapy may be avoided. So I've tried to be simple here. I'm happy to answer if there are any questions. But before concluding, I want to thank my colleague, my resident, Dr. Bilal Ahmed, who helped me prepare these slides, and I'm open to question right after I end here. Thank you all for your patience listening.
Thank you, Dr. Bilal. So next speaker would be Dr. Ali Saveni, and he would be presenting about the tips and tricks of retroperitoneal lymph node dissection. Dr. Saveni, over to you. We would be briefly discussing any questions and queries at the end of the presentation. So for the sake of time, I'm just continuing with the presenters.
Thank you so much, but I just need to share my screen. I'm unable to do so.
Just try once. If you are unable to, I would.
Yeah, if you can share from your end, because I don't have a button here to share my screen, I'm afraid.
Okay. I've shared it.
Well, that is brilliant. Thank you so much. Well, first, allow me to thank yourself and the organizing committee for inviting me to give a talk. And it's a great crowd to follow, actually. So I'm going to be talking about retroperitoneal lymph node dissection and testicular cancers, indications and techniques. So if we move to the next slide, please. So I'm not gonna basically we're just gonna talk about the RPLND, the key indications for it, and different ways, whether open laparoscopic or robotic, and then talk about a bit of complications as well. Next slide, please. So thank you. So my colleagues have been very great in discussing. So I'm not going to take much time. Testicular cancer, you know about the epidemiology of it, and as you know, it's a cancer of young men. Normally, the most common type is non-seminoma, germ cell tumor. When it comes to older men, then becomes seminoma, and of course, young men with undescended testes, also seminoma. And Dr. Bilal nicely discussed about the lymphatic drainage, because embryologically they are intra-abdominal, descend to the scrotum, yet their lymphatic drainage remains intra-abdominal. Next slide, please. So that's the lymphatic drainage pathway. As you know, from the left side remains on the left side. So we're talking about the para-aortic, pre-aortic, and the right side goes to the paracaval, pre-caval, intra-aortic caval lymph nodes. We have to remember that because that will have therapeutic and technical implications when it comes to the RPLND. Next slide, please. So we talk about the stage of testicular cancer. It's been discussed before as per Dr. Aurora, and there are different types of staging systems. So we'll be concentrating on the stage 1 and the further stages. And each stage has its own indication for RPLND, whether we agree or not, but we'll discuss that as well. So the next slide, please. So we'll talk about the role of retroperitoneal lymph node dissection. So we talk about stage 1 and different stages. For the stage 1, the clinical armamentarium differs across the Atlantic. So as you know, our colleagues, the North American, the American colleagues, they are quite into a primary RPLND for even stage 1 testicular cancers, while the European, including yourselves and ourselves, so we are talking about post-operative chemotherapy, possibly therapy, RPLND is not probably the best option in stage 1 testicular cancers. However, there are certain indications that might push us towards RPLND or push our colleagues towards RPLND when you talk about high-risk primary tumor factors. And that will be shown in the following slide, please. And back, so, yeah, thank you very much. So when you talk about the previous one, please. Thank you. So the indications for primary RPLND, if we go back to the previous slide, please. Thank you. So for the stage 1, for the non-seminomatous germ cell tumor, it's done only with the high-risk tumor factors, as clearly mentioned by Dr. Arora and Dr. Bilal as well. So when you have a non-seminomatous germ cell tumor, if there's a lymphovascular invasion and or the presence of embryonal carcinoma. When it comes to seminoma, and I would say that cautiously, when you have a large tumor size, more than 4 centimeters, or there is a re-testis invasion. When it comes to stage 2A, stage 2B. So as a primary RPLND across the water, they would do it rightfully so on low volume disease. While it comes in Europe, then if you have a residual disease or relapsing disease, the presence of normal tumor markers, then you would go for RPLND. And of course, you have the patient preference. If the patients decide to avoid chemotherapy, or you have a patient compliance issue. So remember, in certain parts of the world, a patient may not be able to have close follow-up, for example, when they are sanctioned for surveillance, and that's why, or they may not be able to, financially afford chemotherapy. Then probably one surgery might do the trick. The following slide, please. If we look at the surveillance versus RPLND, so I would quote basically Hejra et al. Paper in 2018, and they looked at around 240 patients. They were comparing RPLND versus surveillance in stage 1 non-seminomatous germ cell tumor, and actually patients with surveillance fared better than RPLND. So just to tell you that RPLND may not be the best option in stage 1 non-seminomatous germ cell tumor, unless if you have certain criteria, as we mentioned, high-risk primary tumor factors in non-compliant patients. Next slide, please. So what about for the post-chemotherapy retroperitoneal lymph node dissection? If you have, again, as mentioned by Dr. Arora clearly, according to EUA guidelines, if you have a residual retroperitoneal mass more than 1 centimeter post-chemotherapy for non-seminomatous germ cell tumor, or if you have, and I would say that with caution, CT PET negative seminoma with a residual mass of more than 3 centimeters, and these are very selective cases. So, as rightfully said, we don't throw CT PET for every testicular cancer. There are certain indications for it. And we know that the FDG PET has a high negative predictive value, and it's not before 2 months after completion of the chemo, as clearly mentioned, because seminomas tend to respond after completion of the chemotherapy, so don't rush into that. And not only that, the inflammation and desmoplastic reaction following chemotherapy makes the operation very formidable. And if you have, of course, a chemo-resistant disease, so you have a disease progression clinically, biochemically, or radiologically despite chemotherapy, then that might be an option for you to stop, think about it, and then offer surgery. Next slide, please. Contraindications, of course there is. So when you have an extensive metastatic disease that's not confined to a peritoneum, and again, that's the rule. There are exceptions, and I'll talk to them in a minute. And of course, if you have poor surgical candidate, if they are unfit for such a major morbid operation with such a high anesthetic risk, and you have an uncontrolled infection, of course, you have to control the infection. Now, arguably, let's say for the sake of argument, if you have a young, healthy man who has not only retroperitoneal but also thoracic metastasis, finish their chemotherapy, and you have still large residual disease. So the retroperitoneal lymph node dissection becomes not only therapeutic but also actually diagnostic, as clearly mentioned by Dr. Arora. They have, let's say, a rule of thumb: 40% of non-seminomatous germ cell tumors post-chemotherapy mass, they could be necrotic fibrotic tumor. Another 40% will be probably mature teratomas. Another 20% only will be viable cancers. So for the sake of argument, if you have this young man with multiple chest nodules remaining after chemo, big retroperitoneal lymph node, you remove that node and it comes as necrotic fibrotic tumor, then there's a very good chance that the pathology of his chest metastasis is the same. So this may be a factor to persuade you not to go for thoracic surgery. So that would be the indication for RPLND in the presence of extra retroperitoneal metastatic disease of pulmonary one. Next slide, please. Like any other operation, I hope you agree with me that retroperitoneal lymph node dissection is probably one of the biggest operations in the urology armamentarium. That's why proper preparation is very important. Staging, CT abdomen, pelvis, and chest. Then for high-risk patient, according to IG triple CG, you do consider CT or MRI of brain. Then, of course, pre-assessment clinic. We talked about the bleomycin and the effect on the pulmonary function. So those young lads, normally they are fit, but the chest will be riddled with the chemotherapy, especially if it's bleomycin induced. Then you have to check the functional studies. Of course, tumor markers, renal function, fitness, and proper counseling regarding fertility and sexual function. Next slide, please. So there are several ways to skin a cat, and I say that with almost respect. So there are different templates how to deal with the retroperitoneum. So you have the bilateral template resection. So when you do bilaterally, normally, if you have gross bilateral disease, or if you have right testicular tumor with, let's say, right-sided residual lymphadenopathy, then as you know, because right tends to cross the left, you might offer them bilateral template disease. However, while doing so, you have to do nerve preservation, preserve the sympathetic chains. And I have to stop by and say, retroperitoneal lymph node dissection is such an uncommon operation. Therefore, it has to be really centralized in regional centers who would do a good number of these procedures. And my colleagues who worked in the UK, Mr. Asla, for example, who's at the moment, he knows well that according to the improvement of the outcome guidelines, they necessitate that you have to have a catchment area of 2 million to be able to perform RPLND. And even in those big centers with big catchment area, the average number of these procedures is only 6 per year. So that's why you really have to have good expertise to be able to perform this procedure, to be able to preserve the sympathetic chain if you decide to go for the bilateral template. So if you look at the picture in the middle of the slide, so that's a unified template. So if you have a right-sided tumor with paracaval or intra-aortic cable, then you can choose to do the right template completely, and you might sacrifice that part of the sympathetic chain if you have no choice but to do so, but at least you have the left side intact. Now, for the left side tumors, the solution is easy. You just do a left side template. And of course, the templates are anatomically bordered by superiorly by the renal vessels. So on the left side, laterally by the ureter organodal, medially by the anterior part of the cava, and inferiorly by the bifurcation of the common iliac. On the right side, renal vessels, laterally the gonadals, medially the anterior part of the aorta, and then inferiorly by the bifurcation of the common iliac vessels. Next slide, please. Everything in life has pros and cons, advantage and disadvantage. So when it comes to open retroperitoneal lymph node dissection, the advantage, it has proven oncological outcomes. It's been practiced for decades. It has excellent control, of course, because you use your own hands, your assistant hands, and you are working around the big massive vessels, the red dragon and the blue tiger, I call them. And if there's any problem, then you have your hands to control the bleeding. But the advantage is, of course, it's a major operation. You're unzipping the patient from top to bottom, long recovery, all sorts of complications which I'll go through them. Next slide, please. So I'm just giving an example. So this is a British Association of Urological Surgeon Guidelines patient information leaflet. I would strongly encourage you to use these kind of templates if you want to counsel your patients. And these are the risks. I can show them to you. So 10% anejaculation. You have chylitis. Unfortunately, I had more, all sorts of complications with my RPLNDs. So chylitis is quite a draining complication. So you send the patient home with a drain, and it takes ages, and you have to put them on TPN, you have to put them on somatostatin for a long time until that settles down. Then, of course, wound infection, incisional hernias, parotic ileus, bowel hernias, adjacent organ injury. So, for example, the kidney, that would be also up to 10%. Blood transfusion, that's it's not an uncommon thing, and sometimes we use a cell saver. And then the possibility of them needing further treatment, it depends on the histology after RPLND. Next slide, please. And other rarer complications, but even more sinister complications. So if you look at the anesthetic risk, cardiovascular risk, other structures, if you look, one of them is written actually the pancreas. And My last RPLD was done laparoscopically, and the patient ended up injury with the tail of the pancreas. And the patient was with me for 6 weeks until he recovered. Even death is mentioned, so it's not a trivial procedure. Next slide, please. So this is a courtesy from my colleague, Dr. Khalid. I took the pictures from him. So you can see this patient with a large residual lymph node disease, and you could see the two open incisions. The one on the right side, you can see the prior to the resection. Then you see the specimen on the left side, and you can see it's beautifully shaped from the vessels down to the IVC of the pelvis. So if you are going to contemplate a retroperitoneal lymph node dissection, might as well just do it properly. Next, please. With laparoscopic, so people say that you can, if you can do anything open, you can do it laparoscopically. There is some truth in it. When it comes to RPLND, that becomes very challenging. And there are several ways to do it. So you can do it transperitoneal, retroperitoneal. If you choose to do it template, you can actually, as urologists, we are used to laparoscopic kidney positions. So you can go laterally, you can mobilize the colon, and then go retroperitoneally, and then use the boundaries and attack one template as opposed to other. However, if you look at the picture down below, even though this is a robotic retroperitoneal lymph node dissection, but also can be done laparoscopically. And in fact, I worked with an excellent gynecologist who does that. So patient reverse Trendelenburg, and you incise the retroperitoneum at the level of the common iliac vessels from both sides. You lift the whole retroperitoneum almost like a curtain. You have the assistant and a paratractor lifting all that up, and that takes you straight to the retroperitoneum onto the vessels. Of course, the first encounter you'll find the IMA, the inferior mesenteric artery. Some people advocate dividing that artery and proceeding, but if you can preserve it, that's great. Then you can continue with your RPLND. Next, please. So, it's needless to say that the advantage of the laparoscopic and the robotic is minimally invasive, fast recovery, less pain. From my very humble experience with retroperitoneal lymph node dissection, if it goes well, patient goes home on the next day. If it doesn't go well, then you're talking about patient, if still alive, touch wood, the patient will be in a hospital for weeks and weeks and weeks. And it requires a lot of manual dexterity, of course, and steep learning curve. And the oncological outcome is written equivalence or debated for one reason. Sometimes surgeons elect to do what's called lumpectomy. And there has been a lot of debate about this, but now that's been clarified in the EAU guidelines. If you look at them, the 2025, they are saying that excision of the lump itself alone is not or should not be performed. So you have to do at least a template resection, if not bilateral template nerve sparing. Next, please. So robotic, again, needless to say, advantages of dexterity, excellent vision, proper control, and the disadvantage, there is still an emerging evidence. So we don't have strong evidence for it, but I'm sure in the next few years we will have a strong evidence. And the next slide will show you basically there's differences. Again, it's quite obvious. So the invasiveness, the open is much higher, the recovery time is much longer with the open, the complications are potentially higher with the ileus, wound infection, wound dehiscence, more pain. But the only thing that open is superior to the laparoscopic robotics is the evidence, strong evidence. But sure, as we did with the laparoscopic robotics, with nephrectomies and the partial prostatectomy, with time, there's going to be more and more emerging evidence to for the minimal invasive procedures, especially the robotic, to supersede the other two. Next, please. We talked about the complications, so I don't want to dwell about this, but the most important thing is proper patient counseling. That's the main thing. And the oncological outcomes, no, that's perfect. You can next slide, please. The oncological outcomes, as we know, the cure rates are very high. RPLNDs, talking about more than 90%. Recurrence rates, even salvage treatment is still successful, and the survival data is very, very promising with retroperitoneal lymph node dissections, if contemplated. Next, please. The functional outcomes, the most important thing is to counsel the patient about the sexual function and the fertility preservation. Ideally, those patients would have been anyway counseled prior to their orchidectomy, penis, sperm frozen, and all of that. Ejaculatory function is very important to counsel, especially if you're doing bilateral template. If you're doing unilateral template, there's a good chance you'll preserve their ejaculatory and fertility function. Next, please. And next, please. So future, some of it actually is present. So we're talking about advanced imaging. CT PET is frowned upon, and there's a very limited role in CT PET. But you're talking about, like, for example, in seminomas. Robotic is ever evolving, and now the new generation of robots with the haptic feedback, the enhanced recovery. It's not future, it's present. As you know, hyperalimentation with high carb intake for the patients, minimal fasting, intrathecal diamorph, wound infiltration catheters, avoiding narcotic anti-inflammatories, and increasing non-steroidal early alimentation after surgery, early mobilization. All these things, of course, they are done. There is the talk about central lymph node mapping. It's been done with certain cancers, breast cancer, penile cancer, why not testicular cancer, but it's still undergoing research. And of course, risk-adapted templates. This is the present, not the future. Next slide, please. So the take-home message, I would say, RP-LND remains vital for selected non-seminoma germ cell patients. Nerve-sparing techniques improve the functional outcomes, patient selection, and surgical expertise. And please remember, surgical expertise is very, very, very important. Centralization is very, very important. These are the keys. And the next slide, please. These are my references, and the last slide is just to say thank you very much.
Thank you, Dr. Ali Saveni. A couple of questions, especially from your take-home slide. I would like my faculty to comment upon that. What I have learned over the years that RP-LND is not to be taken lightly. It's a major procedure and has short-term as well as long-term complications. So you mentioned something regarding that if observation is an option, that's the preferred approach. So what would be your opinion about it?
So you're talking about the observation. Absolutely, Dr. Jahaz. So my own take on it, and I follow the European School of Surgery or Urology, if you like. So if you have a non-seminoma germ cell tumor, then chemotherapy would be your best bet, unless if you have residual mass that requires resection following that. I'm not a strong believer of primary retroperitoneal RP-LND. I think this is a very, very morbid operation. And I think, you know, a wise man said, if the disease causes harm, the treatment should cause less harm. And this might be a strong statement. I think primary RP-LND in testicular cancer, I think, has way more harm than good.
Amandeep, your comments? You want to add something?
Right. So I do agree with what sir is saying. So we at Tata Hospital do about 60-65 RP-LNDs a year. That is pretty high volume. We are really proud of that. It's pretty high volume. But I do agree that we believe that it should be done at a high volume place only. Testicular cancer care needs to be centralized because testicular cancer is rare. RP-LND is an extremely, difficult surgery. I mean, after those 5-6 hours, you feel like zindagi ka ek din shayad kam ho gaya hai. So that is how intense it is for those 6 hours that you are operating. I would not, respectfully, sir, I would not completely agree with the statement that a primary RP-LND should not be offered. We sometimes do offer it to our patients, especially those who have a lot of teratoma in their HIO, in their orchidectomy specimen, and we don't want to give them that chemotherapy. So we might just want to do a robotic. We have, fortunately, the robot available with us in our system. So a primary robotic RP-LND, wherein the patient goes home on day 2, day 3, is something that we offer to our patients. But again, that's probably 2 or 3 of the 60-65 RP-LNDs that we do in a year. Most of them are open RP-LNDs for the huge masses, where apart from surgery, you anyways don't have any option. So you have to go in, but then you should always be operating on RP-LNDs in an experience center. If you feel that you are doing it once in 2, 3, 4 months, you would probably serve the patient better in not doing it yourself and sending the patient across to somebody who does it regularly.
So, rightly, Amandeep, one point is that chemotherapy and radiation is also not without complications.
Yes.
And there is some point in primary RP-LND. It is a relatively straightforward procedure, especially in low volume disease. Yeah. So, any comments from our participants? Balagobi, you want to add something to the discussion? You actually described the seminoma versus non-seminoma. And RP-LND mostly we do for those patients who are either seminomatous tumors which are not responding, which is a rare thing, to be honest.
Yes.
Mostly for the non-seminomatous residual diseases.
Yes, seminomas usually melt with chemotherapy. That is the term that we used in our MDTs. They melt with chemotherapy. If, in fact, even if you've had a seminoma and the post-chemo scan is not showing response, we are actually worried whether we have treated the patient correctly, whether our diagnosis was correct or not. That is how we, go back and start questioning ourselves. So seminomas do terrifically well with chemotherapy.
Okay. So one last thing I would add, as my practice is mostly focused on andrology, I see most of these patients when they are done with their chemotherapy and all, the fertility prospects, practically speaking, are very poor because the semen samples, it's easier, it's more theoretical that you save them and keep them because at that time patient is more focused on his cancers. The overall fertility prospects are usually poor.
Yes.
Anyway,
I mean, in our, sorry.
Dr. Ali, please go.
Yeah.
Please. Sorry.
So,
No, thank you so much. So in our center, it's kind of a protocol. Once we diagnose a patient with testicular cancer, as part of the process is that the patient will submit semen analysis and then basically for freezing, unless of course they electively choose not to. And of course, if you have many patients who have completed their family, yeah.
yeah. So there are success stories, but that becomes a prime concern once you are done with the cancer and also whether you are doing RP-LND or offering chemotherapy, that should be in the back of your mind.
Yes. Yes.
So thank you all. A very nice and productive session on a weekend. So thank you for taking your time and effort.
Thank you so much. Thank you for having us. Thank you.
Thank you very much.
Thank you.